So that was, of course, a brilliant introduction from Dr Thiele about how tuberous sclerosis affects the brain. And now just kind of a little bit more about the nuts and bolts of management in our children. As was mentioned, I work across at the other side of town. Whilst we've got our main TSC clinic here at Randwick, but you know, there's lots of neurologists all over the world who are dealing with these issues with their patients, and it's great to be able to share some of my thoughts and experience with you. So, as an overview, I wanted to talk a little bit more about medication for seizures, improving outcomes, some of the thoughts that we have at the moment about how we can improve our outcomes in terms of treating epilepsy early and minimising side effects from treatment. We'll mention, of course, mTOR inhibitors just briefly, talk a little bit more, as Dr Thiele mentioned, about epilepsy surgery, the ketogenic diet, vagal nerve stimulation, and then just an Australian perspective on cannabis oil derivative treatment that will come, we hope, here. So, when it comes to thinking about epilepsy treatment, as Dr Thiele mentioned, a lot of children have epilepsy present very early, and some of these are the children that are likely to have associated difficulties with autism and learning disorders. For anyone that has a presentation with epilepsy, of course, we want to try and control the seizures as best we can and as early as we can, because it's kind of a little bit analogous to thinking of seizures as being like a little fire. So there might be a little bit of an activity of seizures, and if we don't control that, it kind of becomes a much bigger fire and it becomes more difficult to treat the epilepsy and the seizures. So just to take a step back again, of course, when we're thinking about seizures, we're thinking about a balance of electrical activity in the brain. We're thinking about what we call excitatory nerve impulses, so positive messages balanced against negative messages that keep the usual electrical activity in the brain in the normal range. So what we've got with seizures is too much of the excitatory sort of signals and not enough of that inhibition to keep things settled, and that's what makes seizures that over time without treatment can become more of a raging fire. So our goals really with treatment are to try and prevent seizures from going on without treatment as early as possible. So for any parents of a child with tuberous sclerosis, really what we want is for people to be aware of what seizures might look like, and to talk to their doctor as soon as possible to make sure that we can investigate and see if funny spells are seizures, and then to get the best treatment going as soon as possible. So in the course of that, you know, as many of you will have experienced, as EEG is important, and then going on to treat with medications and some of the other treatment options that we'll talk about. As Dr Thiele has mentioned, you know, thinking about treatment of epilepsy is not just about seizures, of course, it's about the associated features, the learning problems and autistic spectrum disorder features that are intimately linked with the processes in the brain that are happening for someone with tuberous sclerosis. So treatment with the medications that treat epilepsy will have an impact on some of those other features like autism and learning as well. So really, when we're thinking about epileptic activity, you know, it's a really complex thing, obviously, to understand exactly what's going on, but we know that that activity per se is going to have some impact on the brain. We think that maybe, not just with a single seizure, but with many, many seizures over time, that potentially there are changes happening in the brain in terms of what's happening to the nerve cells, what's happening to the wiring and the white matter that Dr Thiele talked about. And that if we let epileptic activity go on unchecked, that leads us to this fire getting bigger, where it's more difficult to treat seizures, and also to you know, the development and worsening of problems with autism and learning. So really, when you think about what's happening for someone with tuberous sclerosis, we start out with a gene change in one of these, you know, in the tuberous sclerosis gene, which is important for so many functions that you've been thinking about this weekend. And the normal developmental trajectory is across here from, you know, birth through early childhood and into adulthood on a background of the susceptibility to epilepsy and the other features of tuberous sclerosis. And we think that those people that have early seizures potentially are in a position where the balance here from, early life through to later on in life gets shifted, so that there's a problem with increasing problems with learning and thinking and autistic features. So we're trying to, intervene in this balance here and produce, a change so that our patients are ending up more down this end. And so the way of doing that, we think, is to try and intervene and help, contain that fire and treat seizures as early as we can, with intensive treatment to kind of swing the balance back so that epilepsy is better controlled and the child is better in all sorts of different ways in terms of their cognition, autistic features. So many of you will have a really good understanding, I think, about an EEG because it's such core business for managing epilepsy in our patients. We're thinking about recording abnormalities and electrical activity in the brain by placing little electrodes on the scalp and then recording the brain wave patterns, essentially. So we're looking really for increased brain wave activity that can be associated with the symptoms, the signs that you might see as a parent when your child's behaviour changes, when movement changes and so on. That could be a clinical seizure. And we're looking for specific areas on the EEG that might be important and correlating that with the symptoms that the child has and with all of their other background characteristics like the findings on their MRI and so on. So I'd like to just share with you the story about one of my patients, and his parents are here. I know they'd be happy for me to share his story. Michelle and Jeremy, at the end, if you wanted to comment from your perspective about your little boy, that would be great, but you don't have to. So this little fellow, just as he was being grown, before being born, an antenatal diagnosis was made of some of the lumps and bumps, the cardiac rhabdomyomas. And so there was a suspicion from early on about him possibly having tuberous sclerosis. This is ideal, of course, that we, identify children even before they're born that might have a susceptibility to the problems of tuberous sclerosis, so that we can really be on the alert to try and manage things effectively as soon as possible. So a genetics consultation occurred before he was born, a huge amount of things to think about as a pregnant mum and dad. And then he proceeded on to have imaging in the first couple of months of life, which did show the cortical tubers and subependymal nodules for him. So we, proceeded then to managing him as tuberous sclerosis. Just to give you a little bit of a feel over time for what's happened in terms of what his brain MRI looks like. He has got definite features, as I mentioned, with some of these changes in different parts of the brain that are the cortical tubers and a few subependymal nodules. And here just another view, again looking from the front at his brain with some of those features that we can see here with different parts of the brain affected. I'm only showing you a couple of slices. So we had that background for this little fellow, knowing that he's at risk for epilepsy, and also to be watching, obviously, for the subependymal nodules over time as well. So going back to his management, he had his first appointment in the first few months of life, and ideally, really, we want to see him from a neurology perspective almost as soon as he's born, to be able to provide that information to his family, to just learn a little bit about seizures and to know, how we can really to establish a relationship and to move forward working closely together. So it was within the first few months of life that we were able to do our first EEG, which looked good for him. We talked about seizures and we established that he did in fact have the TSC2 gene mutation. So we embarked then on a management program of frequent EEGs just to kind of track progress with what was happening with his brainwave activity as he grew and changed over the first months of life, knowing that this is kind of a key time to try and intervene if we can for him. So it was at about 6 months that we started seeing some changes on his EEG. Here's a picture of an EEG. You don't have to be an expert in these things, of course, but just to show you that when we put all of the different leads on the scalp, we look then at the balance of electrical activity between different points on the EEG, and then we get these traces of brain waves looking on the right-hand side at the top here and on the left-hand side at the bottom. And you can see some of the characteristics of those brain waves but especially you can see some of the sharper activity over here and some of the what we call higher amplitude, where there's a little bit more energy happening with the electrical discharges on that side. Here's another picture just showing again on the left-hand side some of the increasing epileptic discharges that are associated with an imbalance of electrical activity in his brain. And in fact, from some of the previous pictures that I showed you, he had tubers in various different parts of the brain, but it's you know, our eye is focused on the left side as being the area that seems for him to be more important in terms of you know, increased electrical activity and the potential to generate clinical seizures. So over recent years, you know, neurologists everywhere really have been thinking, you know, how can we try and you know, improve the outcomes of our children by intervening as soon as we can. We have limited information that suggests at the moment that even when one sees some of these changes on an EEG, that this might be the time to start with treatment. It's a hard decision before we've got, you know, really strong evidence, because we're obviously thinking about, you know, medication that can have side effects before having clinical seizures. But I think that, you know, there are many of us now that are impressed enough with the information that we have to say, let's carefully and cautiously go ahead and treat children when we're seeing these patterns, because we know that the follow-up is usually the development of clinical seizures. So in talking together about this with his family, we decided to go ahead and start treatment with a modest dose and to continue our management in terms of looking at how he was going in himself, the most important thing, but also what was happening with his EEG. So our assessments for him, of course, are not just thinking about what's happening with seizures, but how is he going in himself with his development, his social interactions, his language. So he was doing quite well overall, but there were a couple of things that were just a little bit behind the normal with gross motor and cognitive skills, doing quite well with fine motor skills and language. You know, over recent years, again, with the uncertainty about treating early before clinical seizures, we thought, well, you know, shall we give him a period of time off medication to see if in fact he's not going to need this medication because he hadn't developed any clinical seizures and his EEG looked pretty good. So we said, okay, let's take him off medication and see how we go, with family very aware of watching for any symptoms that might be a clinical seizure. So we took him off medicine. His EEG was looking really good, but within a few weeks his parents contacted me, you know, with real concerns that maybe we were starting to see some things that might have been suppressed with his anticonvulsant treatment. So we did some more EEG monitoring, which showed, you know, things that correlated with what his parents were seeing, and we restarted him on medication, which quickly settled the clinical spells and settled his EEG somewhat too. So just giving you a bit of a sense for what happened after that, he continued to have a little bit of difficulty with his language, but doing pretty well overall. And over time he did develop some more focal seizures, so of course we would increase our dose of medication. One of the things that's really important in working with your neurologist is to think about optimizing the treatment from the point of view of minimizing side effects. So we were thinking for him at this point, you know, are we getting to a stage where, having been on Sabril for a period of time, maybe we're at risk for some of the increased side effects, particularly in terms of visual field defects. And we thought about building in another medication at that time with topiramate, with a view to kind of minimising any potential side effects with Sabril or vigabatrin. So fast forward a couple more years from now, we've continued to work together really closely, and at the moment he is taking 2 medications with Epilim and Topamax, or sodium valproate and topiramate, and doing really well overall. So that just kind of sets the scene with a real situation with people, which is what we're all here about, of course, to think about the sorts of issues that we're working through. But really standing back, the principles are, you know, early treatment, as we've discussed, optimising symptomatic control with minimising side effects. So we want the maximum anticonvulsant effect, and we don't want side effects. We want to kind of get the best balance there. So we start with low doses of medication. We increase as needed for each individual. We start with a single medicine if we can. We might need, you know, 2 medicines, and like some of, you know, Dr. Thiele's incredibly complex patients, maybe children and adults who've been tried on many, many medications over time. So just a couple of points about the sorts of medication. I think I would, strongly agree about vigabatrin being the place that we start for tuberous sclerosis. Of course, our medications work in all sorts of different ways, and that's an important thing to talk to your doctor about, so that you have a sense of what's happening with the medicine that we use. It's really about trying to balance that excitatory sort of activity in the brain with the electrical impulses versus the inhibitory ones. And one of the things about vigabatrin is kind of couched in its name here. One of the chemical sort of messengers or neurotransmitters in the brain is this thing called GABA. And vigabatrin is a medicine that helps increase the amount of GABA in the brain, and that's one of the great chemical messages in the brain that kind of helps with suppressing overactivity of the electrical impulses. And I think we're all still really interested in exactly why that works really well for people with tuberous sclerosis. There are a number of other medications, of course, which work in sort of, slightly different ways, but the same kinds of principles about controlling the balance of electrical activity. And then steroids of various kinds are important, especially for infantile spasms early on. So we try and figure out what might be the best medication for any child at any time, and that might vary over time. And then we want to make sure that we've got a good system in place for monitoring side effects of medication. So, families and patients need to really be aware of what the side effects of each medication might be. We won't go into those specifics today, but, with each individual it's important to talk about those things and for people to be aware. And in an ongoing way, we're really monitoring for how any child or individual is going on their medication. What's going on? Could anything be related to symptoms be related to medication that we need to kind of bear in mind and follow up in terms of getting that best balance? Blood tests are important because a lot of our medications can affect cell count, so the white cells, the red cells and the platelets in the blood. The blood chemistry can be affected, and kidney and liver function can be affected as well. So we need to, variably monitor blood tests for patients. Eye reviews are also really important because some of the medications can affect visual fields and pressure in the eye and so on. So whilst your primary doctor will monitor that with you, we often also draw in our ophthalmology colleagues to have a detailed review of some of those features to see that we're still in a good balance in terms of potential side effects with treatment. And then there can be additional things like a renal ultrasound, which is important to see if there might be crystals forming, which can occur with some medications, particularly in combination with the ketogenic diet. So Dr. Thiele posed so many questions that we all share about what's going on with the brain and tuberous sclerosis, and I've posed just a few more of those in terms of treatment of epilepsy. Some of them, again, just to recap, what's the optimal frequency of EEG recording in early life and thereafter, but especially in early life when we hope we can intervene and change outcomes for children. What about, the optimal timing of starting treatment? We talked about some of those issues with the family that I presented to you today. And what about, how we best monitor for side effects of medication so that we can make medication changes to minimise any problems with side effects during time. So, a number of the neurologists in Australia here have been talking together. Dr. Riney and I have talked about this a lot of times, and with our colleagues, about thinking for our population, how do we try and ask these questions and answer these questions by working together a little bit more, and like Dr. Thiele and many of the other TSC clinics worldwide, kind of pool our experience so that we can get some of these answers as soon as possible. mTOR inhibitors, you'll have spoken about at this conference a lot, and it's been fantastic that our Randwick TSC clinic has been able to offer treatment with mTOR inhibitors for a number of patients. So, of course, we've started with SAGA treatment, and then some opportunities for involvement in trials for patients with epilepsy. And then, we're making, or Dr. Lawson in particular is making local observations about treatment response, and also the other impacts of mTOR inhibitors on social interaction, language, the other features that are so important and intimately associated with epilepsy and tuberous sclerosis in the brain in general. So we're still waiting on a lot of summarised information about the big trials, but it's coming, and it's really exciting to see what mTOR inhibitors are going to offer for TSC patients in the future. Just to turn to some of the other treatment options for children and potentially adults, of course, as well, who have very refractory epilepsy despite optimal medication management. So the history of epilepsy surgery dates back at least to 1909, not nearly as far back as cannabis oil derivatives, but even though it seems like a big thing to consider epilepsy surgery for your child, there's quite a lot of experience in our medical community about epilepsy surgery. And so really, because this is a big deal, it's a matter of having a really comprehensive assessment by a multidisciplinary team to figure out whether this is appropriate to suggest or consider for any particular patient. So, you know, a detailed assessment that's going to bring you a recommendation about whether surgery is recommended, is likely to produce much more benefit versus the potential side effects of surgery. So there are a number of operations that might be considered for any one person. The obvious thing is to think about removing a single tuber if there's one particular area of the brain that seems to be creating the seizures. Sometimes a bigger area needs to be removed because of the kind of networks that are associated with the focal point of the epilepsy. So it might not just be a little area that you can see on the MRI. There might be kind of a network of communication that's generating a seizure that needs to be removed all at once for the greatest benefit in seizure control. And for some patients, another procedure called a corpus callosotomy is important, where the two halves of the brain that are joined by a white matter kind of bridge, if you will, is divided, and that can be especially helpful for those patients who are having a lot of drop seizures. So, you know, your specialised team will kind of think through what's going on from the point of view of the MRI and then the EEG, starting with the scalp EEG, to figure out which of the parts of the brain are actually causing the epileptic discharges like theirs. So there'll be some areas that aren't important for generating seizures and some that are, and that's going to help direct the surgeon's eye to where an operation may be helpful. Along with figuring out which part of the brain seems to be important for generating the seizures, of course it's also important to see what that part of the brain is usually doing in terms of background brain function for that person. So I've just shown you here a little drawing of a brain from the side and from the top with all the different parts of the brain and just some of the areas that might be important in terms of speech and language. So here the motor production of speech, reading comprehension in the back here, sensory sort of speech areas, so hearing and listening and understanding speech. So not only do we have to figure out where the epilepsy is coming from, but what's that part of the brain doing as well, because if we're thinking of removing it, what will be the impact on the patient for losing that part of the brain. So a lot of information is put together by your team, and that team will involve a neurologist, the surgeon, a neuroradiologist to look at various different kinds of scans, the nursing team of course, and a psychologist to think about what's happening with the thinking part of the brain to put alongside of all of this. So we do usually more a detailed video EEG to try and figure out where the seizures are coming from. We look at things from an MRI perspective and functional MRI, where which parts of the brain are active during an actual task, like a thinking task, reading, writing, whatever, speaking. We also do a number of other sort of neuroimaging studies, including a PET scan and a SPECT scan, and there might be other additional studies that are done in some centres as well. So these ones are what are called functional imaging studies, where not only do we look at the pictures of what the brain looks like, but we figure out what the brain's doing. And with the PET scan, it's a matter of seeing what's happening with glucose metabolism, because that changes in an area that's active with seizures. And we also look at blood flow, which also changes in an area with seizure activity. So really it's a matter of putting together a whole bunch of different layers about what's happening with the brain and the seizures for that patient, together with the neuropsychological assessment, any other testing, to figure out what might be the best path forward regarding surgical options. Sometimes, if those layers of information don't correlate very well together, We even need to do more detailed monitoring with EEG done actually with electrodes resting on the brain itself, or even deep into the brain. Again, the objective of this is to map the area where the seizures are coming from, and also to map areas in that area in terms of what's happening with brain function. So this is a complex process of figuring out where the seizures are coming from and what that area of brain's doing. And again, all of this information is put together by your team to bring recommendations about the way forward for surgery. If a surgical procedure is recommended for you and your child, then of course the monitoring after surgery is really important, with figuring out how the procedures impacted on seizures. Not only seizures, but again how the child's functioning in terms of the rest of their interaction with the world, the speech, the language, the social interactions, all of those features. And in many cases there are all of those benefits for children who are good surgical candidates as well. So if we're doing well from a seizure point of view, we'll consider weaning medication, which of course brings with it the benefit of decreased risk of side effects of medication. And really the likelihood of seizure freedom is very individual dependent, as you can imagine. And in experienced centres, which is where epilepsy surgery should always be done for people with tuberous sclerosis and other complex epilepsies, there's a pretty low risk of complications with the expertise that's been built up over many years and decades. And for those folks that have more seizures after epilepsy surgery, sometimes a repeat procedure might be helpful. So there's talking about epilepsy surgery outcomes is tricky because it depends on which series you look at and which group of patients you look at. But just as one little example for you from a centre in Miami, an established surgical centre, reported recently for about 29 patients. 55 or about half of patients were seizure free after a couple of years following the procedure. And it certainly seemed, in looking at a bunch of patients together, that those who have a very clear area of the brain that seizures being generated from, that's clearly removed based on what you look at with your post-surgical MRI and the histology around that area of the brain, so what the brain cells look like under a microscope, those are the times where it seems like we can do the best in terms of a really good outcome for the patient. And of course the converse to that is that for those patients with tuberous sclerosis where there are discharges generating seizures that come from all parts of the brain, then these are cases where we don't want to recommend an operation, because the chances of having that be successful after a big procedure are likely to be much less, and we don't want to put a patient at risk of any side effects if we think that the likelihood of having good seizure control is low. So what about the ketogenic diet? Well, this again has quite a long history actually of some decades, and maybe even longer than that. And basically the principle is that in the past, people with epilepsy who had a change in their normal eating pattern, especially into a fasting state, had a significant improvement in the number of seizures that they were having. And so this is really where the ketogenic diets stemmed from. So it's really based on the fact that we usually have a set of nutrients that come from our diet that looks a little bit more like the figure down here, where there's mostly carbohydrates, so grains, breads, fruit and vegetables, things like that, which compose the most part of the diet, a little bit of protein and a little bit of fat. And from that carbohydrate, the body generates glucose, which the brain uses as an energy source. When we think about the ketogenic diet, we end up pushing things so that the nutritional content in a patient's diet is much more with fats, and the energy that's generated from that is ketones that the brain then uses as an energy source. And this is what seems, we don't understand it exactly, but this is what seems to have a really beneficial effect on decreasing seizures. So we typically talk about the amount of fat to protein and carbohydrates, so you often might hear about 4:1 or 3:1 ratios. When we're thinking about an optimal diet for a patient, of course, it's really important to make sure that the essential vitamins and minerals are there as well. And you know, for any child's growth and development, obviously, working with our dietitians, we want to make sure that there's an appropriate amount of carbohydrate and protein to make the child grow in a healthy way. So that's part of the monitoring of the diet over time. There are other options like the modified Atkins diet as well, which is a little bit more liberal with a little bit less fat in the diet, and the kind of hard work at home with making the diet run is a little bit easier. We're measuring carbohydrate a little bit more rather than all of the different food groups is more the style of the diet. So in thinking about the ketogenic diet for any child, it's important that the family receive information from their dietitian and neurology team, which is probably the nurse and the clinical nurse consultant in the team, and to sort of think about what's involved in the diet, because it is, you know, it does take a lot of effort to provide a different diet for one child versus the rest of the family. But clearly, if we think it's going to make a big impact in the child's life, you know, a lot of families do a great job with managing a ketogenic diet for their children. When you're actually on the diet, if it seems to be the right way to go for your child, we like to have a bit of a look at what's happening with the ketones over time as a measure of how the diet's going. Medications are typically switched over so that there's not so much carbohydrate, because we're trying to use mostly ketones as an energy source. It's important that we have a sick day management for the child, so that if the child's not able to eat normally, we've got kind of a plan to make sure that they stay safe if they're unwell. And then, of course, we review progress over time to see how the diet's working, and oftentimes we can actually decrease medications again a little bit to minimise the risk of side effects if the diet's really having a big impact. There are some side effects in the early days. Children can be a little bit drowsy. There can be other specific side effects then, but those often go away, and in the longer term, the sort of gastrointestinal symptoms often can persist a little bit, but are often manageable as well. The lipids do tend to go up over time. Mostly we tolerate that, but it's something that needs to be monitored for any child. Renal stones, I mentioned, can occur, and we watch for that. We're also monitoring growth and bone health, amongst other things. So this is one of Dr. Thiele's many great publications and comments on the ketogenic diet, and just a small group of patients here, but an important little kind of a set of data for you just to give you a sense of things. So she looked with a group of her colleagues at 12 children with tuberous sclerosis on the diet, varying in age from little infants up to 18-year-olds. And there was a significant response, so this response rate of 50% reduction in seizures at 6 months on the diet in about 90% or so of patients, so that's pretty powerful as a management tool to help seizures. And in fact, in a smaller proportion, even still, you know, nearly 3/4, 90% reduction or response rate at 6 months, so that's compelling. And some children, in fact, after a period of months, were free of seizures. That's our ultimate goal. And along with this, of course, all of the other benefits that might go with controlling seizures. So in this particular group, follow-up was for at least a couple of years and a mean of 2 years. And I'm sure she can comment about longer-term treatment as well. There's good information out there that you can look up about ketogenic diets. I've just given you one little tidbit here from the International League Against Epilepsy. So you can look these things up online. I've given you the website there for lots of bits of information, and just another little bit of a close-up on, you know, the book list that might be available, helpful hints, patient stories and so on, that can be a really important resource for families. Just a couple of comments about vagal nerve stimulation. So again, for those folks where medication, you know, is not adequately controlling seizures, the ketogenic diet can be used. We think about epilepsy surgery, and vagal nerve stimulation is one other option. The vagus nerve is one of the very important nerves that runs from the brain out to the body. It does a lot of things actually, and in sending messages out to the body, it's involved in various functions, including how the heart beats, digestion, breathing function, things like that. And it also seems that, you know, the messages that come back up through this nerve to the brain are important in the network that generates seizures for people with tuberous sclerosis and other epilepsies. So the idea of kind of harnessing this biology here is that we can use a little pulse generator that's put in under the skin in the chest, which has a little wire that runs from that device up through the neck and is just laid against the vagus nerve in the neck there. Now, this little device sends out messages, little electrical stimuli at intervals, which travel up through this nerve to kind of reset the brain a little bit, if you will. So there's this programming wand that the epilepsy clinic, where the vagal nerve stimulators are monitored and looked after, is used to program the device. And for example, you might have a little burst of stimulation through the stimulator every 30 seconds, every few minutes, like about 5 minutes. And also the patient at home can have a magnet where they can use to run across the device to actually give another little stimulus if the patient feels that a seizure is coming on, or to help treat a seizure at the time. There are some side effects like everything, so even up to 50% of people with a vagal nerve stimulator can experience some changes at the time that the device fires. So sometimes a little bit of a hoarse voice, a sore throat, or a cough. Usually this is tolerable for most people. There are other side effects though that can be more important. Infection in a proportion of people might mean that the device needs to be removed. Sometimes there can be breathing irregularities. So we're always looking at that balance of getting the best treatment of seizures and making sure it's tolerable for the patient. And again, it depends on kind of what population and what reference that you look at. But vagal nerve stimulators for treatment of epilepsy are often, about more than 50% helpful in 50% of patients, or maybe even up to 90% in one little study of patients with tuberous sclerosis that was reported a while back. So just before we talk about cannabis, and just a couple of comments from the Australian perspective to finish, I just wanted to echo Dr Thiele's thoughts, and I hope it's come through as I've been chatting with you about our approach in the clinic in Australia, is the importance of these other features, with the autistic spectrum disorder features and so on, and this entity that we call TAND now, tuberous sclerosis-associated neuropsychiatric disorders. So, all of those things about anxiety and mood and general functioning that are really important. I think it's essential that patients and families review these with their doctor on a regular basis as well, because we often have solutions, again, as Dr Thielen's mentioned, that are kind of life-changing in terms of quality of life, in addition to thinking about epilepsy management. So just a comment from the local perspective about cannabis products for epilepsy. It's fantastic and fascinating, isn't it, to hear about such a long history of cannabis, in a medical setting that might bring some benefits for people. And certainly there are, experiences more recently for patients with severe epilepsy where products of cannabis provide significant benefit for their children. Of course, a lot of in Australia, a lot of the issues that have come up about medical marijuana use have been driven by families looking for solutions for their children with severe epilepsy. It's important to remember, though, that for some kids, the benefits aren't there. So we don't understand exactly which kids are going to respond and why. We need those answers, so we kind of got more work to do. In Australia, it's been one of the challenges has been to find a good product that's available for use for families. And in New South Wales, there's been quite a lot of work done over recent months in liaising with one of the companies in Britain that actually is the same company that the US teams are liaising with for their clinical trials. So we've made some ground in forming an alliance, I guess, to work with that British company to provide a product which we think is going to be good for use for local patients, which is really exciting. So we kind of need to work more on getting more information, making this available wherever we can, as we can, for Australian people, and also looking, though, at what's happening in a sort of a controlled way to see what we can learn as quickly as possible to figure out the way forward. It's been challenging in some ways in our environment. The problem for families trying to treat their children with an agent that they hope is going to control their epilepsy and overall improve their quality of life, because of kind of some of the legal ramifications and the backlash, that goes with thinking about these products being derived from cannabis. And really it's about openness and cooperation, and as physicians we really want to work together with patients to try and, you know, find the best outcomes, and so that openness and cooperation is really, really important. In New South Wales, over the last just few weeks, we've had an announcement actually about the progress that's been made with the clinical trials that are planned. And one of the things that you'll all want to know is sort of timeframes. I don't think we have definite timeframes, but the hope is that we'll have some trials at the near to up and running stage in 2016. We are looking at the same product. Where is it? This one, Epidiolex, which Dr Thiele mentioned, and then another product called Cannabidivarin. Whew, I need more practice at that, don't I? So that's another derivative that the same company are producing. So there are a couple of products that might be important and helpful. So, you know, watch this space really. You can go to the website, and I've got the website here that I can show you in a minute. This is up on our New South Wales website now, just with a little bit of a briefing about where we're up to. So, you know, there'll be a limited number of patients that will become involved. There's been a really good chunk of money set aside to try and do some of this work to make this medicine available and to try and think critically about what it's doing so that we really learn from being able to treat patients. And it was great to see from Dr Thiele some of the sorts of inclusion and exclusion criteria that will become part of our local trials here. Those things haven't been released here, but they'll be along the same lines as what's been presented today, which was really nice to see. So you can look up these information sheets yourself. And here's just the websites to go to for some of that information. So a lot of this is being driven by Dr John Lawson and Dr Deepak Gill, one of my colleagues across at the Children's Hospital at Westmead. And of course the rest of the neurologists and others are, you know, ear to the ground to see when these things will become available. We're keeping a bit of a list of our local you know, people who may need to be considered for treatment, and you can also go and register interest yourself on the website. The opportunities here are going to be for the most severely affected patients, I think, because there'll be a limited supply of medication, just like in the US. We just need more information, don't we, to try and generalise this treatment if it's going to be the best thing for our patients as soon as possible. And then those of you who come from out of state or New Zealand will be thinking, well, what about, you know, other places outside New South Wales? There will be a plan and a comment kind of coming together for the other places in our region, and your local neurologist will have a sense of that. So, you know, again, it's a matter of kind of keeping in touch with your local providers to figure out what's happening in your area. And that's it.